Hi, I'm Steve Alberts. I'm a medical oncologist at the Mayo Clinic in Rochester, Minnesota. I'd like to take this opportunity to talk to you about a study that we had recently performed looking at the use of Oncotype DX for colon cancer, a 12-gene panel that helps estimate the risk of recurrence for patients who have undergone surgical resection. During the study, we had evaluated the use of the panel for predicting the risk of recurrence in patients and therefore the potential need of adjuvant chemotherapy. During that trial, we had enrolled patients through 17 centers. All of the centers who were involved in the study were centers that had experience in managing patients with resected colon cancer based on certain criteria that had been set at the beginning of the study, that being at least 60 patients a year seen for potential adjuvant therapy. As part of the trial, we assessed the value of the 12-gene panel in estimating risk and therefore helping to guide decision-making for the use of adjuvant therapy. As many of you know, there continues to be a lot of difficulty in making decisions for patients who have undergone surgical resection of their stage 2 colon cancer. For patients who have high-risk stage 2 colon cancer, those with T4 tumors, evidence of perforation, or inadequate lymph node involvement, we've traditionally considered the use of chemotherapy. For patients who have mismatch repair or MSI high tumors, there has been evidence to suggest that the use of chemotherapy in that setting is of little value. However, we're left with a large number of stage 2 patients that are considered intermediate risk patients. And for those patients, it continues to be uncertain as to the value of adjuvant chemotherapy. Using tools like the Oncotype DX assay for colon cancer, it has been possible to better characterize the risk of recurrence and as such help better educate the patient as well as the treating physician as to any potential benefit of chemotherapy. In this regard, the study looked at a large group of patients who were being seen in the clinic following surgical resection of their stage 2 colon cancer for discussion about adjuvant chemotherapy. During that particular study, the physician was asked to provide his or her estimates about the risk of recurrence and their thoughts in regard to the use of adjuvant therapy, particularly if adjuvant therapy was something that they felt would be recommended. If so, what type of adjuvant therapy, either the use of a fluoropyrimidine alone or the use of FOLFOX, or alternatively to use observation. During the course of the study, we had enrolled about 221 patients. Once the patients were evaluated and the initial estimates were obtained in regard to the use of chemotherapy or observation, the 12-gene panel was performed on the resected specimen, and then with the recurrence score provided to the physician then met again with the patient to further discuss the use of adjuvant therapy. By using the score at the time of the patient's second visit, the recommendations in regard to treatment options changed in approximately 45% of patients, and in the majority of those patients it was moving treatment from the use of chemotherapy to observation, indicating that the score did help better define the potential risk and made the physician as well as the patient more confident in the recommendation of observation as opposed to chemotherapy. In several instances where the score came back as showing a high risk for recurrence, the use of chemotherapy went up in those patients compared to the original recommendation. It is important to certainly stress that this score helps predict the risk of recurrence but does not reflect the benefit of chemotherapy. We continue to be in an era when the use of adjuvant chemotherapy for stage 2 colon cancer patients remains of uncertain value. To date, the evidence to support the use of chemotherapy in this group comes from trials such as Mosaic or some of the NSABP trials that really looked at high-risk patients, not these intermediate-risk patients. We know for the high-risk patients there is some potential value to the use of chemotherapy. The hope is that the use of the Oncotype DX colon assay will hopefully provide better direction in choosing those patients who might best benefit from the use of adjuvant chemotherapy. In addition to looking at the use of adjuvant chemotherapy in decision making, we also performed a study looking at the economics based on this decision analysis. By making decisions, particularly to lessen the use of chemotherapy, recognizing the overall survival of patients, cost of performing chemotherapy, and the management of patients who may have side effects of that chemotherapy, the cost analysis study that was performed showed that we indeed can make a meaningful impact on reducing the cost of healthcare for this patient population and hopefully preserving a better quality of life for patients, particularly for those who don't need chemotherapy. So in summary, with the study that was done, it really does appear to indicate that the use of molecularly guided assays to assess the risk of recurrence does impact on decision making and hopefully ultimately impacts on better care for our patients and a better quality of life for our patients, as well as ultimately saving healthcare dollars. Thank you, and I hope that this information is of benefit to you.